Howdy. So this is the penultimate lecture. I guess it's the last lecture of the class, since next time it's going to be a Blackboard review session at the normal class time. And then the finals on Friday. And so for our last lecture, for our last lecture, we're going to be talking about pharmacokinetics. Okay, so pharmacokinetics is something we've talked about a lot in the class, but we haven't had a lecture specifically devoted to it in all of its nuances. Well, we have had lectures devoted to it, but here's a kind of we haven't had a lecture devoted to pharmacokinetics from the particular perspective that I'm going to be taking here in this lecture, which is really more about drug biodistribution in terms of how to time drug dosing. Okay, and so like we've talked about all through the class, right, there's factors that affect whether a drug's going to reach its target site. And active drugs in vitro may be inactive in vivo again. So this is, again, taking into account the patient. So we're thinking a lot about the patient here. Okay, so what pharmacokinetics is we're analyzing in this case is we're analyzing the concentration of the drug in the body as a function of time. So that's what the kinetics mean, right? And so like we talked about before when we were talking about the liver and this metabolism, we're talking about what's known as ADMET or ADME tox or ADME if people avoid the tox, but everybody should be talking about the tox. So that's absorption, distribution, metabolism, excretion, and toxicity. Most drugs, as we've talked about before, when you give them orally, are going to go through the GI tract, and they're going to pass through the liver and into the bloodstream. So that's how most thing, right? Remember, they're going to go from that portal vein, they're going to go into the liver. So that was that first pass metabolism we talked about before. And then they're going to be bioavailable after that. And so this percentage of drugs that makes it through that first pass of the liver, they're going to see the liver again. So after they've been circulating in the bloodstream, so basically absorbed from the stomach, remember, you go through the liver, out into the bloodstream, and then they're going to hit their target receptor and circulate for a while, and then they're going to end up back getting metabolized by the liver a second time, or however long, they're going to, every time they circulate, right, they're going to end up being passing through the liver. And at a certain point, they're going to get metabolized by the liver that second time. Well, let's not say a second time through, but they're going to, at some pass through the liver in the future, the liver is going to metabolize the drug, and then the drug's going to be excreted. And so we need to be able to predict that with a high degree of accuracy, because that's what's going to determine how you dose the drug, and it's also going to determine drug-drug interactions, etc. So there's a lot prior to 1990, there was a lot of, I'm not going to, again, this isn't a history class, but this was assessed during the development phase. But now we are trying to think about ADME, ADMET, or pharmacokinetics the whole time, basically. So the whole the hit and lead generation. So this is even before we've gotten into animals, into preclinical studies. We're already thinking about ADMET and PK properties. And that's because drugs were falling out of studies at too high a rate. And it was due to these PK properties. And so they were trying to make their process more efficient to make sure that the drugs that are getting into clinical trials will be drugs that aren't going to have some other fatal flaw in the body that wasn't predicted through these in vitro studies that you use to choose your hits and leads. Okay, so there is 3 structure-function relationships in drug development. And that is the primary target activity, right? And so this is what we're going to be talking. This is, the pharmacodynamics. These are these in vitro studies, etc. But they also mean how is it going to act at its primary target in the body of a patient. Now, the ADME properties, and so that's the absorption, distribution, metabolism, and excretion properties, and the toxicity or safety profile. So these are these 3 things that they're looping together. So absorption and distribution, just like we drew before, right? Things are going through the liver to systemic circulation. And this includes, they're going to end up passing the blood-brain barrier, all this kind of thing. And this story, this picture that we have right here is basically an orally available drug through the stomach and small intestines going out to systemic circulation. Okay, so as we talked about before, orally taken drugs need to pass the gut wall. They're going to have to pass a couple of fatty cell membranes, and so they got to have the right balance of hydrophilic and hydrophobic to pass through the membranes, not stick or not be unable to cross. Orally active drugs usually obey Lipinski's rule of 5. Polar drugs can be administered. You can do this by IV. And you can also target them. I would say about this last part, it says polar drugs, my last bullet point here says polar drugs can be targeted versus gut infections. Now let's think about that. Why would that be? Well, if a drug's really polar and you've given it orally, it's not going to be able to have, or it likely doesn't have the right balance of hydrophilic or hydrophobic character to cross the cell membranes needed to get out of the gut. And so that means it's going to stay in the gut, which means that if you have a gut infection, you could take a polar drug orally and it will remain in the gut to be available to fight that infection because it can't cross out of the gut. Okay. Properties impacting absorption and distribution. So these again, it's solubility and pKa. This is also lipophilicity, so log P. So again, we talked about log P, and log D just takes into account the pKa's of the aqueous phase that is partitioning into, and the pKa's of also any ionizable groups on the molecule, molecular weight, and polar surface area. And so here's an example of this from real life. And so this is Nostoc is a cyanobacteria, and one of its basically immune system compounds, its compounds that it uses to fight off microorganisms is this cryptophycin. And so this cryptophycin inhibits tubulin polymerization. So anytime something inhibits tubulin polymerization, it can lead to apoptosis, and so it can be a good way to kill cancer cells. So it can have interest as an anti-cancer drug. So cryptophycin is not shown on here, but basically cryptophycin was not going to be able to be used in vivo, and then its other what they had to do is they had to subsequently derivatize it to be used in vivo. So we can see derivative 1 here, the IC50 is super low. So it's 4 picomolar. So remember we're saying like low nanomolar is where we're shooting for. Here it's 4 picomolar. So it's like 1,000 times better than what we were shooting for in terms of a low IC50. But it's really poorly soluble in aqueous solvents. It's not, or it, well, actually it's not that it's poor. It basically has a poor partition coefficient. So it's not able to readily cross membranes. In addition to that, low solubility can actually make it really hard to formulate as a drug, versus when they have this derivative 2. And so this derivative 2, you've only gone up a little bit in IC50, right? You're basically, an order of magnitude. But the in vivo activity is a lot better, and it's a lot more soluble. So what did they do? Well, let's see what they did. What they did here is they added this piperazine group in place of the alcohol. They broke the epoxide here, right? So they added an H-bond donor where there's only an H-bond acceptor, right? And they have the chloride, so that's another little polar group. And then parsing through, that's the main change. And so they've changed, added a little H-bonding character, and they've also added, so they now have 2 HCl salts, so these are both going to be plus charged at physiological pH. And so they've changed a lot about how this molecule, without changing this much about the molecule structure, they've changed a lot about how the molecule is going to partition when it sees a membrane, what it's going to do when it sees a membrane, how soluble it's going to be in water. And so that's why this derivative here, this cryptophycin derivative, is so much more successful, is that it can handle itself around water, and it can be soluble in water, and it can also cross membranes. Okay, so that is this example, right? So one of the key things is these tertiary amines, which are going to be really basic, right? They're going to be protonated at, so physiological pH is 7.4, pK of these is, let's guess, it's around 9. They're going to be protonated. So if you have an ionized amine, there's a lot of receptors. Remember those neurotransmitter GPCRs, for example. A lot of ionized amines are able to form a relatively strong ionic bond to a receptor. So that's receptor interaction, and they also impart water solubility. So the ionizable groups make them more water soluble. If it's a free amine, this is going to be better able to cross membranes. So solubility, the formal definition of this is going to be the maximum dissolved concentration in a defined solution. So it's basically a thermodynamic property. It's going to affect how oral bioavailability and gut absorption. So that's, stomach and intestine. A lot of drug absorption is done in that small intestine. And so the idea is that you have the solid drug and your drug tablet, which is going to be the medicine, right? So that's going to be the drug, and it's going to be some binders and excipients and a whole bunch of inactive ingredients that turn it into a pill. That's all going to solubilize, and it's going to be absorbed and through the gut and distributed through the body. And then it has to, when it's at its site of action, it has to work. So because drugs must be in the aqueous phase, right, to interact with biological systems. So that's something we've kind of taken for granted, but that's something that's really important. It could be really challenging to do that. So if we want something to be more aqueous soluble, here's some examples of ways that we can do that. We can add ionizable groups. Right, so we went from O-methoxy here So when we add this dimethylethylamine, we now have a lot higher solubility. We add the polar groups here, this ester, right, is going to also likely fall off, remember, and become a carboxylic acid. And that's upped the solubility, 3 times. This is up the solubility a lot more than 3 times, right? That's upped it, around 50 times. Solubility is a function of pK and pH. So this is pKa or pKb here, right? So we'll think of it as pKa. So here's an example of Aleve. It's the pKa of this is this, the pKa they're talking about here is this OH group here. And so its solubility at pH 9 is very high. Its intrinsic solubility as is this species is low. So that means as a protonated species, it has a low solubility. If you take it to something that has pH of 9, its solubility is extremely high because this is deprotonated and ends up becoming very soluble. And that means that it's likely that this is going to get absorbed through your small intestine when that pH does go up. Here's another example, and that is this phenytoin, which is an this is a anti-seizure drug, so anticonvulsant. It means it's given for seizures and seizure disorders. So again, the solubility goes up a bit, again, when it gets protonated. But not as much, right? Because, and the reason is, the difference is that here you're not, this is actually going to be, it's actually a resonance structure. And so in this case, the pK of this, right, is actually going to be really close to 9.0, right? So it's actually it'll get protonated to a certain degree, but it's a small percentage, a relatively small percentage of this that's going to be protonated, but it needs to be protonated to be better soluble. And so that's why the solubility goes up only 10-fold instead of whatever, 100,000, 10,000-fold or whatever, like it does here. So solubility is a function of pH and the pKa of the protonated groups. Sorry, I said protonated here. I meant deprotonated. A percentage of this will be deprotonated for this guy. This guy, I'm pretty sure I said deprotonated. Hopefully I said deprotonated. Here, some percentage of this is going to be deprotonated. Sorry about that. Okay, so adverse effects of poor solubility. Poor absorption after oral dosing. Okay. Insufficient solubility for parenteral dosing. You're going to get low activity from bioassays. And so again, you're like, what's going on? Like, I've given a gram of this drug. Well, the drug's just hanging out at your depot site or wherever. Basically, the drug's not going into the body. And so if you have to do this, the problem is that you don't want a drug, among other things, even if it works well, if the patient has to take the drug 6 times a day, you're going to get poor compliance because people don't want to have to do frequent drug dosing. The only thing people want to do frequently is check their phone. They don't want to be taking a pill that many times a day. Okay, so lipophilicity. So the way that the very traditional way to do this is, as we talked about before, is partition between octanol, which is a polar. It's somewhat polar, because it has that OH group, but you use it to mimic a lipid and then have it organize at the interface, the polar OH groups organize at the interface with your aqueous phase. And so basically you have log P, and so that's where you would get your intrinsic solubility, and then you have log D, and that's where you change the pH of that aqueous phase. And so there's a number of things. One thing we haven't touched on as much as molecular volume, and this is again that polar surface area. You could think of it that way. You could think of it as the molecular weight. In Lipinski's rules, that's where we've accounted for that in our calculations to try and account for this property. And so this has to do with the entropic issues of what's going to happen when the molecule's solvated, and enthalpic issues as well. Okay, so you can definitely, there's a number of ways you can predict it. And a lot of these are actually free, which is nice. So there's a number of ways out there. There's both expensive, really good ones, and there's free, pretty good ones, basically. And so, you don't have to do a lot of this stuff anymore. Right off the bat, you'll still kind of have to do it. So again, what's happening here is that you're getting this permeability absorption. The liver, it's going to go through the liver into systemic circulation, and you get the bioavailability. For log P, the optimal log P for lipophilicity and for GI is between 0 and 3. So this is just giving you some numbers, and here this is with log D, the ideal range again for GI absorption. And so remember, like we talked about at the beginning of the class, crossing the brain barrier is even more stringent about the log P values. So you really want to have this permeability. You want to have your potent drugs. Solubility and permeability are two major factors that you need to have if you want to get maximum absorption of your drug. And so these are really, again, why we want to have these drug-like compounds in our screens. We want to have stuff that already looks like drugs that we're screening, because our ability to get our drug where it needs to go in the body is no small feat. And again, we don't want to be having to take milligrams. So this is predicted dose in milligrams per kilogram. So let's say you're an 80 kilogram man. So that means that you have to take, this is 2, right? So that means if you weigh 80 kilograms, you're going to be taking 160 grams of that drug. So that's kind of a lot. That's a lot of drug. And then think about it this way, right? If it's got poor solubility, then that means you're going to have to take 160 grams of this drug, 6 times a day. You can imagine that there's going to be poor patient compliance. That's why you want to be taking something like a milligram per kilogram. So you're taking 80 milligrams, right? Like a pill, right? Instead of a gigantic, something the size of a popsicle or something. You want to take something that's like a pill once a day. Okay, polar surface areas. So this is the sum of the surface that's surrounding those polar groups, and there's a lot of, you can do this with molecular mechanics software. So that means basically you don't need quantum mechanics software to do this. You can just use molecular, not to disdain molecular mechanics software, but you don't need the quantum mechanics prediction. You can do it with molecular mechanics predicting software. And this is just to remind you, Lipinski's rules are really guidelines, but we won't. We've definitely talked about Lipinski's rules. We've mentioned some of these. We talked about lisinopril before when we were talking about drug design and how they had to modify lisinopril. But notice this. These are substrates of transport proteins. So there's some small molecules that can cross the gut between cells, something like maybe ethanol, for example. But their small molecules a lot of times aren't used as drugs. They have other properties that makes them not fun for drugs, among other things. They can be volatile. And in this case, if they're a substrate of a transport protein. So these are kind of the exceptions, some of the big exceptions to the Lipinski's rules that we haven't explicitly spent a lot of time talking about. And so these are some of these. We have certainly talked about these carrier proteins before. And some of this pinocytosis. This is, we haven't talked about before, and this is cell drinking. And so what happens is the cell can basically absorb a lot of the cytoplasm. Not cytoplasm. Absorb a lot of its surroundings into its cytoplasm. So it's basically can kind of make like what looks like a little mouth and kind of gulp in and absorb its surroundings. But you're like, well, how come that doesn't happen? That only happens with small molecules, very small molecules, less than 200 are going to be the only things that have a chance of being absorbed this way. Weber's rules, again, as we've talked about before, are one thing to note this. Weber's rules are very complementary to Lipinski's rules, as we talked about before, but one thing that's nice is that rotatable bonds. And it also has a number for polar surface area, which is, again, helps us interface this with our computational data. Yeah, that the rotatable bonds, right? Remember, that's why we're doing those kind of ring chain transformations and things like that. So here's some examples. Again, we've done this before. Notice the C log P of doxorubicin. It's low. And cephalexin. So this is so basically doxorubicin we talked about before in the chemotherapy. It's not where we want it, right? Not where we want it. And we could guess that it's C log P is not going to let us cross a lot of membranes if we do Lipinski's rules analysis of this, which you can do in your free time. Cephalexin, this C log P is where we want it. And this C log P is actually, so cephalexin is a penicillin antibiotic, specifically it's a cephalosporin antibiotic. So this is kind of a, I can't remember, it's third gen penicillin antibiotic. I think it's third gen. But basically this is something that you can get in the pharmacy. They give you pills. This is something, a percentage you probably have taken, actually, and you could just take it orally. Doxorubicin, I would venture to guess that no one's taken it, but it's certainly something in this class. But I would certainly say that this is not something, right, that you can give someone in a pill form. This is going to need to go be administered another way. Okay, so there's a number of different ways to administer drugs. Oral is, of course, the ideal. Sublingual, we've mentioned before, is there's a lot of veins right under your tongue, and there's kind of thin mucosa. For an example of a drug that's delivered sublingually, other than one that you're not familiar with, is that's actually how, number one, chewing tobacco is really getting into your bloodstream that way, the nicotine from chewing tobacco, but also nitroglycerin pills for chest pains. If you ever have generally it's going to be an older family member a lot of times that has chest pains and has pills for that. And that what that is a nitric oxide donor. And that nitric oxide is going to help basically with the vasoconstriction in the heart, the cardiac area. And so that's a way to very quickly get that nitric oxide donor to the bloodstream. There's rectal. Again, this is going to be because water absorption's happening there, and so this can be a way for drugs to be absorbed into the body. This epithelial, this is topical drugs. We talked before that it's kind of hard to do this one because the skin's a good barrier, right? The skin's supposed to keep stuff out, so it's kind of not the best one. Inhalation, a lot of times this will be, for example, I think it's either your albuterol for your lungs or for your asthma, or it's general anesthesia. There's a number of gaseous general anesthetics. We talked briefly about halothane, but that's not actually used as much. But there's a number of other ones as well. Injection, obviously, and then implants as well. So oral is really what you want. It has to survive the GI tract, and it also has to be able to be absorbed by the GI tract, and it has to be stable to digestive enzymes. It's got to pass through those cells lining the gut wall. And very hydrophobic drugs are also not going to cross. So we said very hydrophilic drugs like doxorubicin aren't going to cross. If they're too hydrophobic, they won't cross either. Inhalation, it's pretty impressive. But again, like I mentioned, this is general anesthesia or an anti-asthmatic aerosol. Generally, the nice thing about inhaled drugs is that from a drug designing point of view is that they're going to avoid the first pass effect. And so what this means is that they're going to go in through the bloodstream, through the alveoli in the lungs. And that means they're going to be in the bloodstream before they went through the liver. And so that can be good because that way you get a little bit of time for it to get the target before it hits the liver. And that could be nice if the liver metabolizes the drug really quickly. So this is good for anti-asthmatic drugs. It's useful that very polar drugs are unlikely to cross cell membrane. So a lot of anti-asthmatic drugs, if you look at them, are actually very polar. So they stay there in the lungs where they're supposed to be. Okay. Injections used for drugs which are poorly absorbed orally. So this can be something like morphine or obviously heroin. Injected drugs can cause local inflammation. They hit the blood supply. They don't have the first pass effect because they're in the bloodstream already, but they are going to meet the liver, of course. But you're going to have a higher risk of toxicity because you have not given the liver any chance. You haven't given any of your body's methods of detoxifying itself any chance, because basically your body's detox methods are all, either it's liver metabolism or, vomiting, etc., are all to get that drug out of your body before it's in circulation. So be it a bulk response or a cellular response, it's always trying to keep the drug out of the bloodstream. That's the whole idea behind those tox responses. And it's also more difficult to counter the toxic effects because it's all in the bloodstream. It can be easier if someone has taken too much of a pill. A a lot of that pill could be basically absorbed into charcoal, say, or something like that if it's in the stomach. Okay, so intravenous, right? There's a number of different injection methods. So IV is injection into veins, right? This is the most common. IM, injection into muscle, and so this is what this is where a lot of your vaccination is. Sub-Q, subcutaneous, we talked about this before. The main time you probably experienced this if you've gotten a TB test. Intrathecal, this is into the spinal cord, and so this is definitely a serious situation if you need an intrathecal injection, but this can be due to wanting to inject some kind of painkiller and anesthesia to hit those spinal nerves. IP, this is into the abdominal cavity. So there could be reasons to do this. This is going to give you a little bit more unpredictable in terms of profile, in terms of how it hits the bloodstream. Intraocular injection into the eye, that's mainly for eye surgery or ophthalmological procedures. So IV is fastest but riskiest, and so you lower it by doing an IV drip, so you're just getting a little bit IV at a time. Topical, of course, the most famous is going to be a nicotine patch. You can aid the absorption of drugs with solvents, so a lot of this is going to be DMSO, for example. And it's easier if the skin's wet. Okay, so blood level concentration of drugs. So basically you get a sense that ingestion versus inhalation or injection, right, you're going to get a lot higher concentration. They all have kind of a similar tailing over time. So there's some ways to help with drug delivery. There's a lot of people that work on this, and so what they're trying to do is trying to avoid some of these spikes in concentration and have the amount of drug in the body the same the whole time. So a lot of times what you do is that you can encase the drug in a liposome. So this is a phospholipid bilayer. You can then inject the liposomes and the drug slowly leaches out. And so this is great for sustained release. It can also, people look at it for gene therapy. They look at it for chemotherapeutics as well. It can still be bad. The rate of release in the liposomes can still be challenging to control, and it can get depending on the size, it can get trapped in what's known as the reticuloendothelial system, and so this is also known as your lymphatic system, right? So they're trying to get rid of hydrophobic particles that are about the same size as a lot of these liposomes, because they're trying to get rid of bacteria, and so stuff can get trapped there. The liposomes can get trapped there, and so you can have toxicity. So one of the ways to help with this is pegylating the outside. So they add PEG to the outside. And so what they're doing, right, is they're taking something that's a lipid, so it's very nonpolar on the outside, and they're attaching this polar group, which is the PEG. And so what they're doing there is this can help with the lifetime. It protects them from going into the reticuloendothelial system, the lymphatic system. An example of this is Doxil. And so this is pegylated. So Doxil is a pegylated liposome that has doxorubicin in it. And so you can get this as once monthly infusion. So basically you're going to go in to, if someone needs this, they go into their doctor and they get their IV drip of Doxil, and they do that once a month. Another example is microspheres. They're basically the same as liposomes, but they're made out of a polymer instead of a lipid. Okay. Absorption and distribution. All right, so that's once it's crossed the gut wall again, it hits the liver. A certain portion of it is probably deactivated by the liver before it hits the body. And then once it's absorbed, it hits the blood supply within 1 minute. But again, the absorption process is a gradual process. So here's basically, these are kind of a number of complex calculations, again, that are done to figure out the dose that you would give a 70 or 80 kilogram meal. And so here's what they're trying to do is they're thinking about the drug getting into a water compartment from the plasma. And what's going to go, basically how much water the body would need to have in order to get the drug absorbed. And that's going to tell you basically about the dose of drug that you need. Okay. So for these, you get a sense that you want, if stuff is going to be really hydrophobic, it's gonna change its if it's too hydrophilic and too hydrophobic, it's not going to be evenly distributed in the body, because the body, there's water in the body, but there's also some stuff that isn't like water in the body as well. And so what it's trying to do is say, okay, is it going to be evenly distributed or not? And so some examples of drugs that are going to be fairly evenly distributed are stuff like warfarin, which is kind of an unusual thing. Salicylic acid, this is what aspirin will get decomposed to, or not decomposed to, I would call it's an enzymatic decomposition reaction, and it's what it's getting metabolized to in the body. There's atenolol and theophylline, that's from chocolate. Again, these are drugs that are going to be pretty evenly distributed in the body. And you have stuff, unfortunately, like chloroquine, that are going to be bound to tissue components. Okay, so amoxicillin, based on this, is going to be in blood and interstitial fluids. And something like chloroquine, like we saw a second ago, is going to end up depositing into fat. So that's that anti-malaria drug, and it's that one and hydroxychloroquine are the ones that everyone's trying to take for the COVID. And one of the problems with it, right, that's one of the reasons you have to take so much of it. Remember, you take 1 gram a day, and the toxic dose is 2 grams a day, and that's kind of one of the big problems with it. In any case, you get it's because it wants to partition into your fat. Look how much more it likes octanol than water. It likes octanol a lot more than water. This guy, amoxicillin, it likes water more than octanol. Okay. basically, a drug is going to be circulating through your whole body, and so that's why you want it to be very specific, have very specific activity at its target. You want to be very specific for its target enzyme because it's going everywhere. So people think that it's like like a little I don't know, like an away team or like a SEAL team, like seeking out its target, and we talk about it like it's a target, but it's actually everywhere in the body, and that's why you want something that's got a really high activity. It's going to be very potent at its target because it needs to be everywhere in the body, and you want it to work on just its target molecule and work in as little amount so that you can take a pill that's not a lot of drug. You don't have to worry about toxicity or other side effects, and have it go everywhere in the body. And when it interacts with its target molecule, do whatever it is that the drug needs to do. Okay. All right, so here's an example of dosing, half-life, and bioavailability, and this is taken for steroid concentration. So steroid, you could think of it as any one of those drugs that we've talked about before, like estrogen, testosterone, etc., cortisol, that have that steroid ring system. Okay, so basically what happens is over time, you're going to have the onset of the effect. And so that means there is a plasma, let's say you took it as a pill, there's a plasma concentration that's increasing, right? And at a certain point, you're going to get to the concentration that's enough to feel the effect of the drug. As that concentration increases, you'll get the peak effect of the drug, and then the concentration will decrease, and it'll be subtherapeutic. So basically, this is the therapeutic window, what's called the therapeutic window. So notice that it's above the therapeutic window. Ideally, is above where the peak effect is the drug is. Above this, you start to get adverse responses. And below the therapeutic window, it's subtherapeutic. It's not going to give you your desired response anymore. So over time, there can be a fluctuation in the concentration of a drug in plasma. And this can be, so what you're doing here is if you're dosing, right, one of the things is that you want, for a drug that you're dosing, you want to be staying in the therapeutic window. You don't want to be going up to the toxic window. And so that's one of the things that you have to figure out is like from this individual curve, you want to be able to transition to this, figure out how to get the drug so it kind of is staying into that therapeutic window over time. The area under the curve, this is how your body's actual exposure to the drug. So that includes all of the drug that's in the body. So it's not just, we're not just thinking about the therapeutic window anymore. And so this is the dose administered, the rate of elimination. Those are the two things that you need to think about. So at this point for the oral delivery, so when we talked about before, like the steroids, if the steroid's orally delivered, it's going to take some time before you get the max concentration. For IV, your initial concentration is going to be also your max concentration. So you're going to have this nice exponential type decay kinetics here. So again, bioavailability, this is that fraction of the dose that's going to reach circulation unchanged, right? So this is especially important for if the drug's taken orally, because it has to get through the gut, it has to get through the liver, and then it has to get into the bloodstream. So that's going to be a fraction of the drug that's going to be happening per unit time. And so the fraction of the drug is going to look at the amount of drug that's taken by mouth versus the amount of drug that would be taken IV, and assume equivalent doses. And so this is the area under the curve that you're comparing. And so what you want to see is the bioavailability, and the difference of this will tell you if you can give the drug orally or not. This fraction. And so the idea is that if 50% of the drug is available orally as compared to IV, then that's awesome. You can give that drug orally, 50% and above. So we start talking about compartments when we're thinking about drugs moving, basically. If the drug's going to be going from the bloodstream to organs that don't get as much blood, but maybe do more of the metabolism, or maybe it's where the drug ends up being stored. So, for example, the chloroquine example, let's say it stays in your blood, but then it's going to be moving into the fat, and so that's a less well perfused compartment. And so when you were thinking about how that drug works, it's going to have multiple. The elimination phase of something like chloroquine is going to be very complicated, because once it sticks in that fat, it might not come out, possibly for months. And the same with some of those fat soluble hormones, etc. Clearance, again, as we talked about before, there's two clearance mechanisms. There's liver and kidney. At the end of the day, you're trying to get stuff into urinary excretion. So there's a number of kinetic models that have zero order kinetic models for the change in plasma concentration over time. The constant change is relatively rare, but it's kind of ironic because two common examples are alcohol and aspirin, which is like drugs probably. There's just so much more common. So it's kind of unfortunate that the way that their decay in plasma concentration over time is zero order, but that's not how most drugs work. So it's a lot more common to have first order type elimination kinetics, and because back in the day we didn't have computers that were good, so we had always had to put it on a freaking linear scale, but because we couldn't handle exponentials. But you can handle exponentials. Basically, they have this kind of these natural log type decay kinetics. So the concentration at a given time is equal to the initial concentration times e to the negative kt. This probably sounds familiar because it probably reminds you of Chem, and it should. It's the same thing. The elimination kinetics, again, you have this drug half-life that's going to be dependent on the ln of 2, of course. And this is all, again, should be remind you of probably you've experienced this either in Gen Chem or somewhere like that, or talking about radioactivity. So most drugs are going to have this kind of decay over time. Most drugs are first order. So for zero order, it's a constant amount of drug excreted per time. First order, it's a constant percentage of drug excreted per unit time. Okay.